And welcome to today's webinar. Good afternoon, everybody, and welcome to the first of the Autism CRC Autism Awareness Week lunchtime webinar series. These go all week from Monday to Thursday. The focus today is on the early years. My name is Sylvia Roger and I'm the Director of Research and Education at the Cooperative Research Centre for Living with Autism. Over the week we're going to focus on all of our research programs and have a session on autistic voices in research. But as I mentioned, today's focusing on the early years. Before we get started, we'd like to go over a few items so you know how to participate in today's webinar. Here's a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right-hand corner. You're listening in on the computer speaker system by default. However, if you'd prefer to join over the phone, you can just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the question pane of the control panel. You may send these through at any time during the presentation. We will collect them and address these at the end of the panel session. In terms of the early years, the Autism CRC has set an ambitious target to accurately diagnose 50% of children under 2 years of age and 70% by 3. Incorporating cutting-edge genetic and biological research, we aim to reduce this diagnostic age and enhance the accuracy of matching children to the most effective interventions. Today we've brought together 3 of our researchers to present their latest research and some of the outcomes in early diagnosis and developmental surveillance. So our panel today comprises Dr. Lauren Taylor from the University of Western Australia, Associate Professor Honey Heussler, a developmental paediatrician at the Lady Cilento Children's Hospital, and Dr. Josie Barbaro, a senior researcher at the Olga Tennison Autism Research Centre. So I'm going to move on to introduce us, which is Dr. Lauren Taylor. As I mentioned, she's at the University of Western Australia and also works at the Autism Association of Western Australia. She's a clinical psychologist and a research associate with more than 10 years' experience with children, adolescents and adults on the autism spectrum. She currently leads a national project within the Autism CRC looking at diagnostic practices for autism spectrum disorder and has been working to establish a graduate certificate in assessment and diagnosis of autism, which is now in its second year. So welcome, Lauren, and we look forward to hearing your presentation.
Thanks, Sylvia, and thanks for having me this morning here, still in WA, and I'm really excited to present some of the findings on the Diagnostic Practices project. So many people probably know that the landscape of autism diagnosis in Australia is very complicated because we have no national standard for autism diagnosis. This results in quite fragmented processes, with each state having a different approach to autism diagnosis. For example, in Western Australia, eligibility for state funding is determined by an assessment that involves a paediatrician, psychologist and a speech pathologist who all must agree on final diagnosis. This contrasts with the requirements for federal early intervention funding, as diagnosis can be made through any one of a paediatrician or a psychiatrist or a multidisciplinary assessment team. So the aim of this body of research was really to investigate what the diagnostic practices for autism are across Australia. We wanted to find out whether autism diagnosis is being approached consistently across the nation, whether diagnosing clinicians are adhering to best practice standards, and also whether clinicians can accurately identify autism in children under the age of 5. So this research has been really important because autism diagnosis is very difficult. There's huge international interest in autism diagnosis, particularly around identifying autism as early and accurately as possible. That's because an extensive body of literature shows us that early intervention is effective in improving outcomes for young children with autism. So an early diagnosis facilitates access to evidence-based and autism-specific early intervention. Like I've said, the approach in Australia is fragmented, and autism diagnosis is based on the behavioural presentation of an individual. Because the presentation of autism can be so heterogeneous, the identification of autism can be a very complex process. We might see variability in individuals and young children who have quite limited functional language, right up to those who have much more well-developed language, but it's those subtle difficulties in social communication that are their real challenges. The variability in the presentation of autism means that we don't have any one behavioural indicator of autism, and so we can't adapt any one singular algorithm and apply it to autism diagnosis. The presentation of autism also differs across the lifespan, so the process that we're applying to autism assessment and diagnosis might differ for individuals at different age span. The challenges associated with autism diagnosis result in processes that can be very frustrating and very challenging for families at that very early stage of their autism journey. So in the first part of our project, we conducted a survey of diagnosing clinicians across Australia. We surveyed about 175 clinicians, and this slide presents a summary of some of the findings. We found that many families are waiting for a very long time for autism diagnoses. While some of the private services have waitlist periods of less than 3 months, the wait time for an autism assessment in the public sector can be up to 2 years. And we see similar types of similar waitlist times in the United Kingdom, where families are reporting delays of 3.5 years before the parent's initial contact with health professionals and the child being formally diagnosed with autism. The delays between families identifying autism and the time that they get a diagnosis also results in parental dissatisfaction with the diagnostic processes. And also those long waitlist periods, particularly in the early years, can impede families' access to early intervention services. We also found that the cost of autism assessments vary hugely across Australia, and that cost of an autism assessment at the very early stage contributes to the lifelong financial burden of having autism.
Lauren,
yep.
It's Sylvia. I'll just interrupt you for a minute and ask all the panellists just to mute themselves, turn their speakers off until their presentation, because we're getting a lot of background interference. Yep.
Okay.
So if we could just give everyone a couple of seconds to turn their speakers off, and then we'll remind you to put them on once we go over to your presentation. Thank you. See you, Lauren.
Thanks, Sylvia. Okay. So we also saw variability in the cost of autism assessments across the private and the public sectors. So unsurprisingly, assessments in the private sector were significantly more expensive than those in the public sector, and that might compromise access to assessments for families who are waiting for an autism diagnosis. We also found huge variability in the approach to autism assessment across Australia. So the current best practice guidelines for autism assessment and diagnosis recommend that assessments should consist of a full medical evaluation, developmental or cognitive assessment, and assessment of language and adaptive skills, and also incorporate standardised measures of autism symptoms, such as the Autism Diagnostic Observation Schedule or the Autism Diagnostic Interview. We found that in practice, assessments that include all of those components are very rare. The inclusion of measures of cognition, language and adaptive skills was inconsistent across clinicians and differing across services and disciplines as well. But those types of assessments are really important for the differential diagnosis of autism from other neurodevelopmental and behavioural conditions, particularly in the early years. We also found that while the current gold standard measures of autism symptoms do include the ADOS and the ADI, only 3/4 of the respondents are regularly administering those types of assessments. And less than 1/3 of those participants are using both the ADOS and the ADI together, despite the evidence indicating that the use of those two tools increases the reliability and accurate autism diagnosis. One of the interesting findings was that a small number of respondents reported that they had diagnosed autism when an individual didn't meet criteria for the disorder. And those clinicians who had diagnosed autism when an individual didn't meet the criteria had predominantly done that so families could access service or fundings and to make it easier for them to access the intervention or support that the family needed. We also found that very few clinicians are conducting autism assessments in regional and remote areas of the nation, which means that wait times outside of the major cities are longer than they are which impedes access for families in those regional areas to gain assessment services and autism diagnosis, which would again facilitate access to early intervention. So we're working really hard on phase 2 of this project, where we're trying to establish whether clinicians can reliably diagnose autism in children under the age of 5. For that phase of the project, we're giving clinicians videotaped autism assessments and asking them to make a diagnostic rating based on the observations that we're making. We're really hoping that the results of these 2 pieces of work will contribute to the development of a national diagnostic standard so that we can improve practices, make sure that Australia has a high standard of autism diagnosis, and also ensure that clinicians are approaching autism diagnosis in a consistent way regardless of the state that an individual comes from. And I'm working with a fantastic team of people on this project that come from all parts of Australia. We were thrilled to have such a high number of respondents to the survey. We're thankful to all those who did respond, the Department of Social Services and Autism CRC for funding this, and also the great group of people who have helped to work on this project and make sure that we're approaching it across the nation. And that's it from me, so thank you for having me, and I look forward to seeing some of the questions that come at the end.
Thanks, Lauren. What I'm going to do, because we've got a couple of minutes to spare, is to ask you to just explain what adaptive skills are, because I'm conscious we may well have a very broad audience, and you mentioned cognitive, adaptive and communication skills, and I just thought adaptive might be a word that people are less familiar with.
Yep, sure. So when we're looking at adaptive skills, we're looking at people's ability to perform everyday tasks in an independent way. So when we're looking at those types of skills, we might be interested in whether an individual can feed themselves, whether they need support to feed themselves. We're looking at whether they can dress themselves with or without support. We're looking at their ability to communicate with other people and also the way to get on with other people and how they might interact with people on a social, in a social way.
Yep, thanks, Lauren. And you mentioned by acronym the tools ADOS and ADI, which will be familiar to people who are professionals in the autism space but may not be terms that are familiar to the wider audience. So I wonder if you could just tell us a few things about those 2 tools.
Yeah, so the Autism Diagnostic Observation Schedule is a tool that's used quite extensively in autism assessment and diagnosis. It's a tool that clinicians can use to engage a child in play type of activities, and they use the tool to try and elicit the child's best communication and best social skills. So for example, you might be playing with a pop-up toy, and you're looking at whether the child is looking at you while they're playing with that toy, whether they're pointing to it, whether they're sharing interest in that toy, or conversely whether they might be taking the toy and turning their back on you and playing on their own and being reluctant to engage in play with an adult clinician. And that has 4 different modules, so it's used for very young children, it's used for older children, adolescents and adults, and the types of tasks that we use in the assessment would differ. So for adolescents and adults, we're looking more at those core features that indicate that a person has autism, like whether they can engage in a reciprocal situation with you. The Autism Diagnostic interview...
Tried to ring.
Sorry, I'm getting some background noise.
Suggest you send them back saying we've tried to make them fit with, we redrafted to fit with.
Hi, we look like we've got a crossover here with the phone system in our office, so we're just aiming to correct that and to see if we can get the person off the phone while this webinar is going on. So thanks for your patience, and thank you, Lauren, for explaining the ADOS to us. And I think did you get to the ADI?
No, that's when I started to get a bit of background noise. Do you want me to keep going?
Yes, that would be great.
Yeah. The Autism Diagnostic interview is a very long interview type assessment that's done with a parent or a caregiver or somebody who knows the individual who might have autism very well. It asks about the core features of autism, like the person's ability to participate in social interaction, somebody's play skills, and it looks at those types of skills historically and presently, because autism, for a diagnosis of autism, an individual has to have demonstrated the characteristics since they were very young, so that assessment covers right back to when a child was very young up until the current time.
Great, that's great. Thank you very much, Lauren, for that extra explanation, and we'll keep a track of any questions that come through. So what we're going to do now is move on to a presentation on diagnosis by Dr. Honey Heussler, who we know very affectionately as Honey. Now, Dr. Heussler trained at the University of Queensland and the Mater Children's Hospital before spending time in Melbourne at Royal Women's and Children's and the Murdoch Institute. She completed a doctorate in focusing on behavioural and attentional consequences of adenoid tonsillectomy, and she did that through the University of Nottingham, where she was working at the time. Honey's clinical work now at Lady Cilento very much involves developmental and behavioural problems in children, and she's the director of the department there. She also specialises in sleep disorders, and we know many children with and adults with autism struggle with sleeping. And she also runs a specialised clinic in genetic disorders. She has a number of research interests and is involved in a number of our studies across the early years, providing very important paediatric input to us. So I'm going to just ask Honey to make sure her microphone is on, and then to hand over to you for your presentation.
Okay. So my sort of discussion today was largely going to be around an overview of the diagnosis of children with autism, recognising all of the things that Lauren has spoken about as being significant issues for us here in Australia. When a child first starts to show signs of abnormal trajectories, families often rely on social and family information until they present to a medical practitioner. And there can often be some delays at this stage. They may or may not be referred for allied health interventions or assessments prior to seeing a paediatrician. And that paediatrician may either make a diagnosis or adopt a we need to wait and see approach, and consider the child at risk of an autistic trajectory, if you like. But that can sometimes be problematic in itself in terms of accessing the right interventions if there's not a label as such. If a diagnosis is made through a multidisciplinary assessment, then feedback and planning is really important. You can see the next slide that there are often a number of things that we need to focus on, particularly from a paediatric perspective, but as well as trying to understand where the child is coming from. So in the diagnostic processes, we consider both the biology and the environment of the impact of both of those on the child, as well as trying to get a good understanding of the sort of phenotype or how the child presents and is functioning. And this is really around social communication, attention, some of the adaptive skills Lauren was talking about, and also the sensory difficulties that child might find challenging in today's environments. With the next slide, we talk very much about sort of a functional approach to this and an understanding of the child. And as you can see from this slide, there's lots of things that we need to take into account in terms of that function for learning, not only at school age, but also in the preschool age. So the child's ability to focus and concentrate, to communicate, to remember information, to process information, organise it, and attend. This is often complicated by sensory issues, poor sleep, dietary restrictions, poor attention, and difficulty in selecting out the right bits of information. As medical professionals, we also consider the genetics and the biology behind all of those things and the environment, and take all of those things into consideration in determining how that child is functioning and where their challenges most lie. And it may be in something like, for example, the most limiting thing for a child might be around their profound anxiety or their lack of sleep. And so all of these things we take into account. With the next slide, really our aim of diagnosis is to diagnose children as accurately as possible, as early as possible. And why do we want to do that? And I guess there's a couple of things, is that the early years are certainly very critical times in terms of brain development. A lot of our brain development happens in the first 2 years, and it's really important that we maximise the impact of any interventions that we can get. And certainly the most evidence is around early intervention, so it makes sense that the earlier we get in with that, the better. It's also important that when many of the genetics and other potentially treatable causes of autism, the earlier you impact on the child's development, the better. And you can see that we think there are many risk sites for autism, and many of them in this sort of synaptic region that you can see in that very complicated diagram on the right. And it's a question as to whether in the future, probably not at the moment, many of these things we may be able to maybe not cure but ameliorate the impact of them, and certainly of various genetic things, and certainly the earlier we do that, the better. When we think we do, next slide, we do know that comprehensive early intervention does help children with autism, particularly when we're looking at the functional outcomes, and that's related to early brain development. You can see in this diagram the real development of sensory and language and cognitive function occurs with the development of the neurons in those early years, first 1 to 2 years. Next slide. So the diagnosis actually, and this is probably where I think a lot of the challenges lie, is that it's based on symptoms, not cause. Not like you have a particular disorder such as a genetic disorder causing an absolute thing like sort of a muscular dystrophy, which is very classic sort of symptoms. But there are very different profiles and presenting things, although common themes running through the diagnosis of autism. And there are a couple of different systems that are used throughout the world with this, and probably the most common one that we use here in Australia is DSM-5. And this is really, it's changed in the last few years from DSM-4 to 5, really trying to bring all the different disorders in under one umbrella. So we have autism with and without intellectual disability, with and without language, and with or without other conditions, and really focused very much on understanding social emotional reciprocity, non-verbal communication, difficulties with relationships and repetitive behaviours. It also brings into account social pragmatic and communication disorder, which in some respects may have been lumped under a PDD-NOS label in the past by many in order to try and access services. This is often a very profound disorder and may present looking very much like autism in the playground, in that these children may well have difficulties understanding the social complexities of language. The other system commonly used is ICD and ICD-10, which is less prescriptive but very similar in terms of social communication difficulties, repetitive behaviours and peer relationship difficulties. The gold standard of diagnosis is, next slide, generally recognised to be a multidisciplinary assessment by a team with experience in child development. And practically this doesn't always occur, as is quantified by Lauren's study. There are multiple assessment tools used, and that depends very much on the presenting features of the child. There are children that you see where it's very clear that autism is the diagnosis very quickly, and there are others that need much more complex and more detailed assessments. And multiple assessments can be used in terms of assessing and understanding language, cognition, adaptive function, so function of the child, sensory difficulties, and again the ADOS and the ADIR. The ADOS is a particularly helpful tool in that it gives opportunities to look at the child's play and their function socially. The ADIR also is another very good tool, but extremely long and difficult in a resource-pressured clinical environment to actually implement. The other thing always worth considering when we're talking about presentations of children is that children will act differently in different environments, and sometimes the presentations that we get in a one-on-one hospital environment are quite different to what one might see in a challenging environment in a daycare setting. Socially, children may be very different with peers, and particularly if a significant receptive language disorder may be present, they may be a lot more comfortable in a more predictable environment such as home. So it's always worth getting an understanding of the child's function in different environments as well. The process is generally fairly similar, I suspect, across most environments. And certainly the earlier the diagnosis, the more severe the symptoms are usually. So people with milder diagnoses may not present until they're really significantly challenged with social challenges later on, and then only in retrospect do you see that these challenges have been around for a longer time. Usually the process starts when concerns may be raised, and this might be either through screening or when parents start to compare that child's features and function with others of the same age, so that when they start to attend a daycare setting or a school. At that stage, a referral through to specialist services may occur, and this occurs differently throughout the world. In Australia, it tends to be to child development services, but in some circumstances may be to child and adolescent mental health services. The assessment will then usually involve multiple professionals: speech, psychology, early education, occupational therapy, paediatricians or psychiatrists. And there will be a number of processes and assessments that might go on. There will potentially be other things that might occur to understand the child from a biological perspective, and this might involve such things as blood tests or MRIs, and these are really to rule out biologically treatable causes and to understand the causality of the presenting features that we see. The process isn't not just for the label, although that is often what is seen as the sort of real reason for a diagnostic process, but it's really better designed and better thought of as trying to get a better understanding of the child's presenting features and how they view the world. And remembering that all children are different, including all children with autism, and all present with different strengths and challenges. Once a diagnostic process has been gone through, then usually a team will try and set some goals with the family in the context of the child's function and strengths, trying to look at planning for best evidence-based interventions that child is likely to benefit from. And this is one of the things that we're trying to do within the Autism CRC is, once we understand the best function of the child, is thinking about which children respond best to which interventions. And I think this is an area for more scope moving forward.
Thank you, Honey, for that excellent presentation. I'm going to keep moving now on to Josie's presentation and come back to questions at the end. So thank you very much. So the third presentation this afternoon is Dr. Josie Barbaro, who is a research fellow at the Olga Tennison Autism Research Centre at the Trobe University. Dr. Barbaro's interests for a long time now have been in early intervention and diagnosis of autism in infants and toddlers, the health of the family and well-being subsequent to diagnosis. Josie's been pivotal in developing the social attention and communication, or SACS, and this has now been translated nationally and internationally. She won the Menzies Memorial Scholars Association Award for, and she has also won the Best Translation of Autism Research Award at APAC last year. Josie leads a project in Program 1 that's looking at further research around the SACS tool. So I welcome Josie and invite you to give your presentation.
Thanks, Sylvia. So today I'm going to talk about the development of the social attention and communication study from its very early beginnings until its implementation now as part of the Autism CRC Core Program 1, and how this has been translated into an app called AS Detect. So as Lauren and Honey succinctly already outlined, the reason why we want to detect and diagnose early is because of the provision of early intervention for children, which does maximise children's outcomes later in life, taking advantage of children's brain plasticity. But what's often forgotten about is the fact that early detection and diagnosis also can lower in the long term parental and family stress. Past research has shown that the main factor associated with parental satisfaction is early detection and diagnosis, so that they are not going on a path of attending one professional to another and being handballed around wondering what exactly is different about their child and not having their concerns heard. So when an early diagnosis does occur, ultimately it does lower parental and family stress, and parents can begin seeking services earlier and actually begin to access professional support earlier for themselves as well, which is really important. We do have to focus on the family unit and not just the child. So on the next slide. You'll see here that the average age of diagnosis currently in Australia is over 4 years, and this is despite the fact that we can accurately diagnose many children with autism by 2 years of age. And what we have found is that current screening tools for autism are quite inaccurate. And the reason for this is because many screening tools miss a lot of children who do have autism, or they over-identify children who don't have autism. So when you have a tool that is both identifying children that don't have autism and also missing many children, you can see that you just can't use these tools to try and identify children with autism. So it's for this reason that as part of my PhD in 2006, I began a study called the Social Attention and Communication Study. And we wanted to see if we could identify children earlier between the ages of 1 and 2 years of age. And currently the SACS is part of the Autism CRC Core Program 1. So this Social Attention and Communication Study, as I mentioned, the first one was in 2006, and now we're conducting a revised version which was improved based on that first study, which will finish at the end of 2017, and this is in Victoria. So across both of these studies, we monitored over 36,000 children during their routine maternal and child health consultations, and this is across these 2 large-scale studies. So during maternal child health consultations, the nurses will be monitoring children's development and behaviour and hearing about parents' concerns and queries as well. So we trained 350 of these nurses on the various SACS items, and the items are various behaviours. So if we click here on the little red flags of autism link, we'll show you the different behaviours that were what we call the key behaviours that would differentiate children with and without autism at these ages. So we would train nurses to look for deficits or absences or difficulties in various behaviours. And these are the key behaviours we looked at, such as pointing, eye contact, response to name, so that if children were not engaging in these behaviours, then it was telling us about a child's likelihood for having autism. So if we go back to the previous slide, we trained nurses to look for these various red flags at 12, 18 and 24 months of age during children's routine checkups, so it didn't take any extra time than usual. And we trained nurses to enter their observations of the children for these items into a database. And this database then quickly gave nurses a result as to the child's likelihood of having autism. So it wasn't about a diagnosis, it was about a child's likelihood based on previous research. And these children who were identified as high likelihood were referred to us at La Trobe, where we undertook an assessment of these children every 6 months until they were 2, and then we followed them up again at 3.5 to 4. And we found that 81% of all of these children identified as having a high likelihood of autism received a diagnosis between 2 to 3 years of age. So we found that this method was the most successful method for identifying autism currently. The next best screening tool for autism has an accuracy of 11%. So we really felt that this was a much better way of trying to identify children with autism as early as we possibly could. So if we go on to the next slide after this one, we used these, so if we go on to the AS Detect, thank you. So we use these results to put them into an app that parents can use. And so this app is called AS Detect. And the reason why we developed this app is because we wanted to bridge the gap between the need for early identification and the differences in different services across Australia and also across the world. So not everyone is going to have a universal maternal and child health system, and even if you do, it may not work as well as the system that we have in Victoria. So we wanted to try and translate this evidence into a mobile application that anybody can use, and it can be in their own home as well. And what this app involves is a modified version of the training that we delivered to nurses so that parents can observe videos of children with and without autism for each of those behaviours that I discussed earlier, and then it was followed by a question. So, for example, it would show a child with and without autism engaging in behaviour such as pretend play. And then it would say, does your child engage in pretend play? And it would give an example like, does your child feed a teddy, for example? And so for each age, there were 12 to 15 items monitored between 1 and 2 years of age. And again, it gives an automatic calculation as to a child's likelihood for autism status. So it would come up with a child having a low likelihood or a high likelihood. And this is based on the evidence of the 2 large-scale studies we've conducted. And again, it's not about a diagnosis, but about likelihood. And so parents are sent the results of their child's, in an email, they're sent the results of their child's assessment and what the next steps are. Because we felt it was really important to be able to tell parents what to do next, what these results mean, so that they're not left with just a result and they're not sure what to do next. And the data in AS Detect is encrypted, so it does ensure privacy and security. So I just wanted to show you an example of one of the videos in AS Detect. You won't be able to hear the vocalizations, but I will talk about what's happening in the video. So if we press play, you'll see here that there's a title slide and it has response to name. And what I'm doing is I am actually saying what a response to name actually means. So I'm saying why it's important and at what age children typically do respond to their name, which is about 6 months of age. So once I begin and discuss what the actual behaviour is, we then move on to a video of a child who ended up with a diagnosis of autism. At this stage, she was 18 months of age. And you can see here that the clinician is calling her name. And I'm discussing about how she's calling her name and this little child is not turning and making eye contact with the clinician. She's continuing to focus on the toys in front of her and is not turning her attention and making eye contact with the clinician. So I'm clearly showing different examples here of this little child in different situations, so that we can show that across multiple situations, this child is not turning to her name call. Then we move on to a child who doesn't have autism, and I'm describing about how this child turns and looks straight away and makes eye contact when he's called. And you can see that we pause on the eye contact to show that the child does turn and make eye contact. And this little girl here, so we're really trying to give as many examples as we possibly can to parents so that they can accurately try to identify whether or not their child is developing typical social and communication behaviour. Now, the reason why we focus on social and communication behaviour as opposed to repetitive behaviours, for example, which of course is part of the diagnostic process of autism, is because we've found that social communication behaviours specifically in infants and toddlers are the behaviours that can most predict a diagnosis of autism. So we've found that these behaviours can reliably differentiate children with autism to children with other developmental difficulties, but repetitive behaviours, for example, are very varied. So one child might line up toy, whereas another child might flap his or her hands. So repetitive behaviours can be very different between different children. So we need to try and focus on the behaviours that are most consistent across different children. So the future directions for our research is that we're going to implement the SACs in Tasmania. So we're going to replicate the method that we used in Victoria in our maternal child health system and do this in Tasmania's maternal child health system to see if we find the same results. So obviously in science we want to replicate our results as much as we possibly can. So we'll be doing that in Tasmania very soon. We'll also be looking at the effectiveness of AS Detect to see how it works in the real world. So we want to evaluate it to determine how accurate and sensitive AS Detect is. So how accurate it is in identifying children with autism and how sensitive it is in picking up those children who do have autism. We also want to evaluate how parents feel using AS Detect. Are there improvements that we can make? Are there some things that they can tell us to make their experience more comfortable? And how do professionals view the app? Are they taking the results of the app seriously when parents present to them with the results? Or are they thinking that it's a Dr. Google type thing? Obviously, the app is based on evidence, so we must make sure that both parents and professionals are on the same page when they are discussing the results from the app. So thank you everyone for listening to our presentations today, and I'm very happy to answer any questions you have about the SACS or AS Detect.
Thanks very much, Josie. To make sure we've got all our panellists on, and we have got a number of questions. So I'll start. We'll go back to Honey. Honey and I think Josie also used the term clinicians. So one of the questions here is who are clinicians and which clinicians are involved in assessment?
Which clinicians involved in what?
In assessment of children with potential autism diagnosis.
I think that probably when I refer to the word clinicians, I refer to all those people that might be involved in a child development sense. So the paediatrician, the psychiatrist, the psychologist, the speech and language therapist, the occupational therapist, the audiologists, physios. So I would refer to all of those people who are involved in a team-based assessment. Ultimately, in terms of the medical component, that tends to come down to the paediatrician or psychiatrist. But that comes much more into the biological sort of role that they play in a team like that. But all of those members bring different clinical expertise to the situation.
Right. I'm just going to keep on with you, Honey. The query that's come through is, how is a child with OCD, so obsessive compulsive disorder, different from a child with autism? And this person said, particularly in terms of repetitive behaviours.
So I think this is where sometimes in the diagnosis very early on for very young children can be particularly tricky. If you were talking about an older child, then usually the child has a much more of a social communication sort of aspect and much more able to do things like respond to name, like Josie was talking about, much more able to explain things than a child with autism might. They might be able to explain some of the compulsions that they have rather than not necessarily being aware of it as a compulsion. So they're kind of different in a Gestalt type of sense, but may look very autistic in some respects. So a child with OCD that needs to, you know, do certain behaviours in the playground, for example, OCD often comes with a lot of anxiety as well, which may mean some of their peer relationships are restricted. So while I'm not able to, I'm hoping I can give you some answers towards that. Sometimes it's not that easy to distinguish between the two, but it comes back to that social communication stuff and trying to tease that out in a child who may well be quite anxious as well. That's tricky, and that's where you need the expertise of a experienced team to get the diagnosis right.
Thanks, Honey. The next one, I'll stay with you at the moment and then see if anyone else wants to pick up on this one. the question is, are current diagnostic tools able to pick up very social autistic kids?
I think that's a tricky question because it depends on what the profile and understanding of the child is, and that's where sometimes the tools aren't always as helpful. My experience would be that the tools we've got are pretty good, and it's a question of what they have that meets criteria for autism, really. And I think that is where it comes back to making sure the diagnosis is right. Is it somebody who has a lot of language and ability to express themselves, but subtle social things that sometimes are not that easy to tease out? But certainly the ADOS has very strong abilities, I think, to tease out some of the quirks and nature of those kids who have learnt to be social in the whole sort of general picture, I would think.
Thanks, Honey.
Yeah.
Yep, thank you very much for that.
Whether you would have anything to add on that?
Yeah, I guess as you were saying, Honey, the ADOS has various prompts to be able to, I guess, identify whether or not a response is a learned behaviour. But it's also important, I guess, to be, discussing or having conversations with parents and teachers as well, so that we can get information from them as to whether or not they actually have identified that children or adults are acting differently in different situations, and that they may have learned a response and are using that same response across different situations. So I guess that's where it's really important that we're getting information from various sources and not just having a direct child assessment, for example.
Thanks for that. Just a couple of quick questions for Lauren. Can you confirm the number of clinicians who responded to the diagnostic survey and whether they were both private and public?
Yes, it was 175 clinicians off the top of my head. At least started the survey. We had 100 complete responses, and we had clinicians from both the private and public sectors. We also had some clinicians who worked entirely on their own in a private sector, and we had clinicians who worked within a multi-team as well. So we had a very wide variety of respondents to the survey.
Thanks, Lauren. And another question for you. Why conduct cognitive assessment when identifying autism?
When we're making an autism diagnosis, one of the criteria that's outlined in the Diagnostic and Statistical Manual is that the characteristics we're seeing can't be better explained by an intellectual disability. So one of the things that diagnosticians may need to do as part of an assessment is to administer a cognitive assessment to work out whether a child has an intellectual disability or whether the characteristics of autism are not part of an intellectual disability. So it's a really important part of distinguishing the right diagnostic label for that child.
Great, thanks, Lauren. So the next few are for Josie. So Josie, these relate to ASD Connect and the SACS. So this question is the SACS freely available?
Yes, so it has been published in various journals, and so basically anybody can observe or look at the items. The training itself, though, it does require training before the SACS is administered. So if anybody is interested in training on the SACS, it's best to contact me, to email me, and then we'll send around details for that. And AS Detect is freely available, which is based on the SACS. So you can have a look at AS Detect first to get a sense of what the SACS training would be like. And the SACS training is basically just a longer version of what AS Detect has.
So the next question is, what are your future plans with ASD Detect, and particular reference to regional and remote families and what you might be able to do there?
So our future plans for AS Detect is firstly obviously to evaluate it to make sure that it's working as we'd like. And we want to make sure that obviously it's freely available to anybody, so regional and rural areas can access AS Detect. We also would like to translate it in various languages as well, so that developing countries can have access to the app. We feel that that's very important. We know that there are going to be 20 billion smartphone users by 2020, and 80% of them are going to be from the developing world. So I think it's really important to translate, but also work hand in hand with those clinicians. But rural and remote areas are really the next frontier for the work that we're engaging in. It's an important priority area for us.
Okay, we've just got a very short minute or so, Josie, for this question. Can you describe the next steps that parents or caregivers are given if they have a child with using ASD Detect who has a likelihood of autism? What's the recommendation?
So the recommendation, so they're sent an email with their child's results and what each of the results actually mean, whether the behaviour that their child is displaying is typical or not, and then it says that the child really needs a thorough developmental assessment, and that they should go to their GP or their paediatrician with the results of this email that describes not only the child's results but the results of our research. So that's the first thing that they should do, is to go see their GP to request a developmental assessment. So they're the immediate next steps. And then we have a microsite with various resources on there, such as the local autism organisations that they can contact and parental support groups.
Great. Thank you, Josie. Well, we're just about at the hour, so I would like to just take this opportunity to thank our three speakers, Honey, Lauren and Josie, for their time today and for sharing their insights with you, both from their research and their clinical experience, because they all have their hands on the ground and working with children and families, as well as conducting research within the Autism CRC. So thank you very much for joining us. Tomorrow we will be looking at the school years, and we would be happy to have any feedback from any of you about this session, and whether it's met your needs and how you have enjoyed listening to our speakers today. So thank you very much, everybody, and we have recorded this session and we will be uploading it through the Autism CRC website for people who were not able to attend or people who would like to listen to any aspects of it again. So thank you very much, all our speakers and the audience, for your participation and all the questions that have come through from you in the last 15 minutes. So thank you.